let me talk about the topic of my presentation. Now, my report is devoted to rather small malformations. These are Spasler Martin 1 to grade AVMs. And what should we do about them? Whether we should treat them microsurgically or treat them endovascularly. This is my conflict of interest. And as you know, there are 4 options to treat AVMs. These are embolization, radiosurgery, microsurgery, and observation. And we believe the embolization is the most primary method at hand, and any malformation should be first considered for embolization. As for microsurgery and radiosurgery, we consider them the additional options we can use for those malformations we couldn't have embolized. And of course, the last retreat is observation, when you simply do nothing. When we developed our own tactics, how to treat malformation, we compared the results for different techniques. They are different. In microsurgery, for instance, the number of complications can vary from a minimal 1, especially for experienced center, and to 21% in less experienced center. But microsurgery gives us the highest level of radicality. As for embolization, when we addressed this issue, you could see the radicality was rather slow, but when it comes to that number of 27%, quite recently, embolization, they started to consider it as a pre-radiosurgery technique or pre-microsurgery technique, but as a primary option. And when adhesive compositions became available, we could successfully treat malformations with embolization and all. Radiosurgery has a number of limitations. Only small malformations can be treated with this method, and when you follow up these patients for the next 2 years, a number of hemorrhages are possible, and the radicality is far from 100%. So when we started to embolize using non-adhesive composition, as our success rate was around 70%, and we consider this result to be quite well compared to that of radio surgery. And since the number of complications was quite low, we consider it this option a curative one. As in any report on AVMs, we talk about the Aruba Trial. A number of endovascular surgeons, after this study was published, they stopped treating patients with unruptured arteriovenous malformation. And since we operated patients with epileptic seizures, and we continue to do so after the Aruba trial because we couldn't find it very convincing, we carried out our own study, taking the patients with hemorrhagic and epileptic manifestations. This slide represents the study design, and we perform. And after propensity score matching, we subdivided them into 2 comparative groups and compared the results. What our results were: most of the patients after the embolization, their status improve, seizures stop, the frequency of seizures reduces as well. And the more total embolization is, the better the result. The partial embolization was 41.2%. In case of total embolization, it was 78%. And if we compare it to the natural course of the disease, and with patients with anti-epileptic drugs after the embolization, both total and subtotal. These seizures recurred in 55% of cases. We also compared the number of complications in the two groups, and we could see that the epileptic group, the number of the amount of mortalities was the number of mortalities was much lower in epileptic patients, and the most severe complications in this case is, of course, a hemorrhage. So despite the fact that we obtained quite a good radicality, we couldn't quite provide quite well prophylaxis of hemorrhages. So there are still patients that are in such a way undertreated, and we have to do something about it. There is a number of techniques that allow us to improve the radicality. These are corking or pressure cooking technique. This is a double catheter or three catheters. We've seen it today during the live case from Kazakhstan. This is using new generation of embolizers such as Fill and Fill Onyx. I can say we have quite a large experience with these embolizers, no more than 100 cases, but I can say that I like it because it's the fast and more radical procedures, and since they use the same substance as in the previous generation, you can combine them in a single catheter, and in case you can close Navium with fill, you can add Onyx. Transfenders embolizations also increase radicality. We could see it as well, and a kissing technique when you put one catheter in the artery and the other in the vein, and you simultaneously inject embolizers on the two sides. This is an example of one patient that is an idle thalamic hypothalamic on the brain IVM. It's been embolized transvenously. You see no complications. This is the MRI and the long-term follow-up. This is an example when at the first stage we work transarterially, and as our grandfathers have been telling us, in the end, you have to close the vein. You haven't closed the vein, you haven't closed the malformation. And in post-op images, we could see total occlusion of the malformation, but in a half year of follow-up, we could see it recanalization. One more example. Here we use two embolizers. What's convenient for fill, it doesn't contain any tantalum. And at the second stage, if you decide to use Onyx, this embolizer, you can see it very well right through Onyx. So you see the total embolization of the malformation. Not all malformation can be properly occluded, and when you try to embolize it at any cost, and sometimes come up with dangerous catheterization, what you obtain is a complication. The most dangerous one I hear when you occlude the malformation totally. And for that reason, when we consider embolization is getting dangerous, we use microsurgery, or if we couldn't occlude the AVM totally. We also use microsurgery, but what the difference in our approach is that we immediately perform it, or we do not wait whether it's rupture or not, and we just transport the patient to the open surgery room and remove the AVM. It is surgically unavailable. We perform radiosurgery. So this is the hypothesis we based our study on, and whether this such an aggressive application of several methods at a time that make this method the most invasive technique than embolization. And we, in our study, decided to see if this kind of approach increased the number of complications. By the time we had operated 537 IVMs, and those patients were randomized into two groups for patients with a multimodal study and a control group that involved patients with embolization alone. We carried out propensity score matching to select groups of 63 patients for a proper statistical comparison, and we obtained the very good radicality in case of multimodal study, and quite a proper radicality in the control group. The recanalization degree was similar for the two groups, and the number of complications was significantly lower in the MT group than in the group with embolization alone. Consequently, you can see the differences in the morbidity mortality rate as well. And finally, when we're talking about small malformation of Spassler-Martin 1, 2, microsurgery here has certain advantages, such as high radicality, low rate of post-op hemorrhagic compilations. They normally do not rupture, and they have very well developed technique. I can say this method is cheaper, especially if we count everything in general, but everything depends on consumables. Microsurgery is less dependent in this respect as for Russia responsible. As for disadvantages, we have to talk about the high risk of neurological deficiency, no opportunity to save removal of deep IVMs. It's very important to have an experienced surgeon on site because the experience is the key factor for a successful surgery. Longer hospitalization time, and patients have problems with social adaptation. For instance, we carried out a study, and after microsurgery without neurosurgical complication, 14% of patients couldn't come back to their work because their bosses didn't want them to come back. And for the time being, many patients, they have the access to the internet. Many patients don't want surgeries. They want mini invasive treatment. What's interesting all quite old studies where only microsurgery was assessed. We cannot find a pure microsurgical series of patients because all of these cases involve embolization as well. As for the advantages of endovascular treatment, this is a microinvasive technique that is progressing quite fast. We constantly have new devices, and the procedures that were performed 10 years ago are not comparable to those that we performing nowadays that enables you to treat the so-called functional zones. You can easily select proper patients. You can treat IVMs and aneurysms of any localizations, proper social adaptations. Normally, patients do not hide the fact they've been embolized, and for the time being, most patients prefer embolizations. As for disadvantages, this procedure is consumables dependent. Its radicality is lower than in case of microsurgery, and hemorrhagic complications are always an opportunity, especially in case of subtotal AVM occlusion. This is a characteristic example of a medulla oblongata AVM. This is a functionally important zone that was included in a single stage without any complications. As for multimodal treatment, we've been talking about requires us to perform a total or subtotal embolization, and if total embolization is impossible, we shift to surgery. So we combine the advantages of the both technique. Here you see an example of such a procedure. There you can see subtotal occlusion followed by a single stage microsurgical AVM removal. In our series, we looked into the treatment of Spascular Martin grade 1 and 2 aneurysms. Endovascular treatment alone was performed in 159 patients. The IVMs were in different parts of the brain, and we broke them into the two stages. Year 2014 was a kind of the breaking year when we decided to introduce the multimodal tactics in question. And you can see when we've introduced this technique, we could see the better results. So the radicality reached almost 80% in the patients with multimodal treatment. Our results were almost perfect. Recanalization was only in one case, and it was most likely kind of coagulated one. And we treated this patient additionally, but you can see both morbidity and mortality was 0 with the efficiency rate of 95.8%. Of course, it's not a 100% safe technique. I guess if you cure 100 patients in such a way, you're gonna see a certain complications. And when we did 183 patients, the morbidity was 3 and mortality was 2 patients. And in conclusion, I'd like to say, since the topic of my report was Spascular Martin grade and 2, grade 1 and 2 AVMs, I should say that In this case, one should start treating patients endovascularly, and if you can't occlude this malformation, you have to apply surgery immediately.